COVID-19 status in the country, but also other matters regarding the ministry. Today I would want to start off by talking about the field of cancer and what we are doing in the ministry. As you know, in the last few weeks we have been highlighting other conditions that have compounded the COVID-19 pandemic in the country. When we have observed that individuals with underlying conditions are more at risk not only of contracting the disease, but also succumbing to it at some point due to low immunity. One of these conditions is cancer. And yesterday we talked about other underlying conditions, including cardiovascular diseases, diabetes, but cancer is one of those underlying conditions that you often find in those who might succumb to the disease. Cancer has been slowly and quietly consuming our people. It is one of the most impacting diseases on our people and health facilities in recent times. Every household in the country has in one way or another been affected by this deadly disease. Recognizing the burden of cancer in the country, His Excellency the President on 1st August 2019 directed the ministry to develop a cancer policy to address the growing burden of the disease in the country. Today marks an important milestone in our fight against cancer in Kenya, and we are proud for the first time to launch the Cancer Policy 2019-2030. Alongside this policy document, we are also launching today the Breast Cancer Screening Pilot Report. The Cancer Policy document provides a framework on how to comprehensively manage the cancer burden in the country through systematic implementation of evidence-based interventions in the area of care. So these are two documents that we shall be launching at the end of this brief. The Ministry of Health has put in place deliberate efforts to improve access to cancer services in line with the Universal Health Coverage Agenda. Through the Managed Equipment Services, or MES, the ministry has availed X-ray, CT scan equipment, ultrasound, and mammography machines to the counties to boost cancer diagnosis. In collaboration with the counties, the ministry has established 10 county chemotherapy centers, which are all operational and fully functional. The ministry has continued to support these centers with appropriate cancer drugs, especially during this COVID-19 pandemic period, to ensure continued service delivery. This means that basic cancer care can now be accessed at a nearby county health facility. And I want to urge our cancer patients on active treatment as well as those on follow-up to embrace and utilize these services. With these cancer treatment and management centers, the number of Kenyans seeking cancer treatment abroad will also be reduced. Additionally, as part of the objective to upgrade cancer care services in the country, the ministry recently operationalized the Kenyatta University Teaching, Referral and Research Hospital, which has very modern facilities for cancer treatment and management. We are also in the process of establishing 5 additional radiotherapy centers at the Moi Teaching and Referral Hospital, Nakuru County Referral Hospital, Mombasa County Referral Hospital, Garissa County, and Kisii County. Focusing on the maxim that prevention is better than cure, the ministry also launched the human papilloma virus, or HPV, vaccine to prevent cervical cancer targeting our 10-year-old girls. And I therefore want to encourage parents to take their 10-year-old girls for this vaccination at their nearest health facility. This vaccine is safe, effective, and life-saving. To all women, I want to remind them that cervical cancer screening services remain available in our health facilities, and I want to appeal to all eligible women to visit their nearest health facilities for screening at least once a year. The ministry has also developed and disseminated the National Cancer Screening Guidelines to all the 47 counties, and I want to appreciate those counties that have continued to make use of these guidelines to prioritize improvement of their cancer screening services, including through continued dissemination to health workers. Ladies and gentlemen, pertaining to breast cancer, it is the leading type of cancer in Kenya, with about 6,000 new cases every year. It is for this reason that the ministry conducted a breast cancer screening pilot dubbed the Breast Health Awareness Campaign, whose report I will also be launching today. This pilot project will guide the scaling up of breast cancer screening services in Kenya. I want to appreciate the Nyeri County leadership, and particularly the Nyeri County Health Department, the Kenya Network of Cancer Organizations, and the General Electric Healthcare for the support they offered that ensured the completion of this pilot project. Indeed, as I have already stated, prevention is better than cure, and embracing screening and wellness checks at individual level is what will make the difference in the fight against cancer and other non-communicable diseases in general. These diseases are silent killers, and more often than not, their symptoms will usually appear when it is already too late. Let us remember that most cancers are curable, particularly if they are detected early enough. Ladies and gentlemen, turning to our COVID-19 situation, today 247 people have tested positive for coronavirus out of 4,147 samples tested over the past 24 hours. This brings to 7,188 our caseload of those confirmed positive for COVID-19. Our cumulative samples tested so far stand at 180,206. Amongst the 247 positive cases today, 242 are Kenyans, while 5 are foreigners. Males comprise 164 and females 83. The youngest is a one-year-old infant, while the oldest is 100. That's, I guess, this is the oldest we have seen so far. The cases are distributed in the counties as follows: Nairobi 153, Mombasa 35, Kajiado 15, Busia 12, Kiambu 12, Uasin Gishu 4, Machakos 4, Garissa 4, Muranga 2, Nakuru 2, Siaya 2, Lamu 1, and Nyamira 1. The distribution of these cases by sub-counties, if we take Nairobi, the 153 cases are in Kibra 35, Westlands 28, Dagoretti North 16, Kasarani 13, Embakasi East 12, Starehe 10, Langata 8, Makadara 6, Embakasi South 5, Embakasi West 4, Kamkunji 4, Roysambu 4, Dagoretti South 3, Ruaraka 3, and Embakasi Central 2. In Mombasa, the 35 cases reported there are from Mvita 17, Likoni 6, Changamwe 4, Kisauni 3, Jomvu 3, and Nyali 2. Kajiado reported 15 cases, 10 from Kajiado East, 4 from Kajiado North, and 1 from Kajiado Central. Busia had 12 cases, 8 from Teso South, 2 from Teso North, 2 from Matayos. In Kiambu, the 12 cases are from Kiamba 6, Ruiru 3, Thika 2, and Kikuyu 1. In Uasin-Gishu, the 4 cases are from Ainabkoi 2, Kapsaret 1, and Tarbo 1. In Machakos, all the 4 cases reported there are in Athi River. And in Garissa, we have 2 cases from Dadaab and 2 cases from Garissa Township. In Muranga, the cases are from Maragua and Kiharu. In Nakuru, 2 cases are in Nakuru West. And in Siaya, the cases are in Alego Usonga, while the case in Lamu is from Lamu West. Nyamira, case is from Nyamira Town. And I believe Nyamira County is the latest addition to the counties now affected by coronavirus. On a positive note, we're happy to inform you that we have discharged 39 patients from various hospitals, bringing to 2,148 the total number of recoveries. And once again, we take this opportunity to thank our healthcare workers for the good work they are performing out there. Sadly, we have also lost 2 more patients to the disease, bringing to 154 our total fatalities in the country due to COVID-19. Our heartfelt condolences to the family and friends of the departed. I would now want to invite to the podium Dr. Onyancha, who heads our Directorate of Preventive and Promotive Medicine, to come to the podium and say a few words about the cancer program and the documents that we are launching today, which we shall do so after we finish with this session. Dr. Onyancha.
Thank you so much, CS, for this moment. And good afternoon, everybody. The chance I've been given is to elaborate on the documents that we are launching today. We are launching the policy, cancer policy, and a pilot report for breast cancer screening, which has been elaborated by our CS. I just want to add a few points to that. Why the cancer policy? I think all of us are aware that last year we had a lot of outcry on the extent at which cancer was affecting our people. And despite that we are responding to COVID, other work is going on because the cancer treatment is also very key to us. And therefore, these are the documents that we have been developing. And I just want to give a slide overview of the policy. Why the policy? This is a blueprint on what we are going to, how we are going to intervene in terms of cancer management in the country. And we have heard that this policy aims specifically to improve awareness and education to cancer prevention and control. We are all aware that the best management of cancer is prevention, because the treatment, usually the outcomes are not very good. So the policy spells out how we are looking at how we can improve the primary prevention of cancers through mitigation of risk factors and their determinants. That is one of the things that the policy is spelling out. The other one is to enhance access to appropriate cancer screening services. As I've already mentioned, that the best management for cancer is actually prevention, and also strengthen the referral pathways for patients with cancer or those suspected to have cancer. Also, the policy spells out how to promote access to optimal diagnostic treatment, palliative care, and the survivorship of cancer patients for in the unfortunate event that we have missed them in the screening and they have been able to get the disease. So we need to strengthen the management, the diagnostic treatment, and the palliative care. This is the supportive care for those who are terminally ill. Lastly, to strengthen the registration of cancer. At the moment, we don't have a very elaborate registration. We want to look at surveillance and information management as far as cancer is concerned, and also promote the coordination, partnership, and financing of cancer control. It is important that we get such guidance so that we can be able to mitigate against the effects of cancer in the country. And therefore, the policy shall be implemented in line with existing national policies, alongside and also legislation through the 5 national cancer control strategies that have already been spelled out. I also want to mention that the report of the breast cancer screening was necessitated because of what we observed, that we have we have screening tools, but yet the uptake is not very good. It was done in Nyeri as part of the pilot county for UHC, and the report that has come out is showing that for sure we have those mammography in every county, especially county referral hospitals, but the uptake is very, very poor. And I want to appeal to the ladies concerned to please take up this opportunity to be able to go and have screened so that we can be able to detect the cancer early. As we heard from the speech, from the brief, is that breast cancer is #1 cancer among the women, and therefore we really want to make sure that we reduce it to that manageable stage. So these particular results that we are launching today, the pilot results, shows the following in brief: that 50 community health volunteers have been trained, and 50 community health extension workers with 33 healthcare providers having been trained in the breast cancer screening. What we are saying is that the caregivers are there, the providers are there. Please take up the service, especially at this point when we are seeing most of the services utilization is decreasing. We are appealing that the ladies should can come so that they can be screened. I just want to take this opportunity as we finish to appreciate our partners for making it possible for this report and the policy completion. We have our partner, the network of the cancer organization, whom has already been appreciated. We want to also appreciate the General Electric for supporting us to make sure that we have the diagnostic equipments in the country, especially the one that's coming up in KU. We also want to appreciate our partner Chai for supporting in the HPV, as we have already had. Ours is to appeal to all the public that when the ministry is making efforts to make sure that the services are available, please make use of them. That is when they can only be meaningful. Thank you so much.
Okay, thank you, Dr. Onyancha. Before we go to our question session, I want to make a correction here. I stated that Nyamira is one of the new counties. I'm reminded that it is not new and that it has recorded cases before. I think we now can open up for some questions from the media.
I'm Brian Otieno from KTN News. I have 2 questions for the DG. I'd like to know the total number of patients who have been treated at private facilities, and also the number of patients in public facilities who have been through the ICU. And also, I'd like you to elaborate on the ban on sanitization booths.
Thank you. My name is Gina Kirori from NTV. I have 3 questions. Can you kindly comment on the study that was released by KEMRI that an estimated 78% are assumed to be asymptomatic, and should this be a concern to Kenyans as we head towards the peak? Number 2 is, why is Kenya's recovery rate so low at 32.47%, yet countries such as South Africa, which have a high number of cases, have reported a 49.90% recovery rate? The last question is that there's some confusion about medical students who are currently under an internship at hospital facilities. Are they supposed to continue on with their internships, or should they be suspended? Thank you.
Wahiga Mwaura from Citizen TV. First question is, please give direction to families who find themselves in a catch-22 situation. One, they lost their loved ones in a COVID-related death and are required to bury them within the next 48 hours. But because of the hospital bill, they are not able to do so. What is the ministry's policy on that? Secondly, I'd like a comment on the research by KEMRI Wellcome Trust that intimated that possibly 2.7 million Kenyans may have already been exposed to the COVID-19 virus. This is from a sample of about 2,500. Is this reliable prevalence from a sample size like that? What does it say about our curve? You're talking about 7,000 here. Could we be looking at a much higher number? And my last question is also, please speak to us on how many COVID-19 testing kits are approved for use in Kenya, and what is their level of sensitivity, because there are concerns about false positive and false negative tests in our country at this time. 3 questions, please. Thank you.
Hi, my name is Graham Kajilo from The Standard. My question is with regards to the underlying conditions that seem to make people die from COVID. Do you have data to explain if these people actually knew of their conditions before they were admitted to hospitals, and what was their level of adherence to medicine before they were infected with COVID-19?
Okay. That's quite a number of questions. Some of them are directed at the DG, and I will certainly direct some of them to him as well. Brian Otieno, Nation. I think your question was with regard to how many COVID patients have been treated in private facilities. And then you also needed to know in the public facilities, those that had underlying conditions. Am I correct? The second part of your question.
Yeah, those who have been, those in public facilities who have been in ICU.
Oh, I see. Okay, we can start with that. Patients in private facilities. We have the data. DG.
We're going to show
DG will respond to that, as well as those in the public facilities that ended up in ICU. We had a question from NTV. A study you mentioned came out of KEMRI stating that Kenyans are 78% of our cases are asymptomatic. Well, we do have a researcher from KEMRI here. I think I will at some point ask him to comment on that, because there are 2 questions regarding KEMRI. One is this one on the asymptomatic rate, and the other one is on the seroprevalence rates. We'll comment on that as well. Why is recovery in Kenya low compared to other places such as South Africa? The DG will expound on this, but I would think that we need to be very clear about what we are comparing here in terms of recoveries. Remember that recoveries are, as we move along this journey, we are admitting people as well as releasing people as we move along. So it depends upon what, which part of that pathway that one is looking at in order to get those numbers in terms of recoveries. I would say certainly that we have a fairly good recovery rate compared to most of the other countries that we have seen that have been hit by this virus. I would say that our recovery is fairly good, generally between 30 to 50%, depending upon what time you look at those recoveries. But DG will talk more to this issue of recovery. You mentioned also about medical students and whether there is a need for medical students to continue their internship. You know, we're at a time of a pandemic. Remember, when a medical student is undertaking internship, that is the student's introduction now to really develop oneself to become an independent doctor. It is practical training. There is no reason why these students should not be deployed out there to one, enhance their learning experience, and two, to also bolster the healthcare workers that we need there. For all practical purposes, these medical interns are part of the healthcare workers. And so we don't see any reason why we need to prevent them from being out there in the health facilities and the wards, helping the other healthcare workers deal with this pandemic. Citizen. Direction for family, that was from Citizen TV. Direction, what can we do about families who have COVID deaths and are faced with a lot of problems, including payment of the bill. COVID deaths, of course, have to be treated in a particular way, and we have a protocol for that. And that is for the safety of both the family and the healthcare workers who are handling this COVID death. And I think those protocols are being strictly adhered to. But of course, we understand that this places families in very difficult circumstances. As a ministry, once we are made aware of any particular situation that might face a particular family because of a COVID death, as a ministry, we take the responsibility to be able to, if it is a public facility, then there is no issue in terms of payment of the costs, because we have said that this is covered by the government. If it is a private facility, we can intervene to ensure that the family is given an arrangement that will be suitable for them to be able to, one, undertake the burial and also make payments in line with what their ability is. And we do facilitate that from time to time once we are made aware of those situations. We have also worked with the private health sector and impressed upon them that we're under very difficult times and they need to be very considerate when they're dealing with people who will be affected by COVID and end up dying. And I believe that most of them have been responsive to what we have told them. And the second question was on the study by KEMRI. I am aware about that study, and I know that that information has somehow gotten out into the public domain. We were really not ready yet for it to be out there in the public domain. But now that it is there and it has come up, I think it is time to comment on it. This is a study that we commissioned, the ministry, together with KEMRI Wellcome Trust. We commissioned to look at the seroprevalence of COVID-19 in our population in a quick way, so that we could get an idea of the numbers of Kenyans who have been exposed to this virus. When we talk about seroprevalence, what we mean is we want to look at people who have developed antibodies to the coronavirus. And working with KEMRI, who developed a very specific ELISA test. I won't get into the details of the type of test it is, but it's called an ELISA test, which we demonstrated is specific for COVID-19 and is also sensitive to a very high level. We were able to use this test and collect samples. The quickest way we could get what we think would be a fairly good representation, of course not perfect, of the population is to go to a place where we can get the samples quickly without having to do a lot of field work. And so we went to our national blood transfusion services, who have blood collection points in different parts of the country. We have about 6 regional centers where most of these bloods come. And we collected samples from these 6 regional centers, blood representing, most parts of the country. These blood samples were then tested against that test to determine how many of them actually had antibody and how many were negative. And that is the data that you have seen. And indeed, we have gathered some interesting statistics out of this study. What the data tells us is that if we look at those places where we had a fairly good number of samples, including county of Mombasa, county of Nairobi, and a couple of other counties, we are able to determine the percent prevalence. In other words, in every 100 people in that county, how many actually have this antibody. And I can tell you, and I will have the researcher talk a little bit more about that, but we have some very interesting data. For instance, in Nairobi, we found that almost over 12% of the population of Nairobi seem to have been exposed to this virus. Remember, we are using a small sample and then extrapolating. So using this percentage, we then are able to look at in the entire population of Nairobi County, for example, the 3 or 4 million, how many people would this translate to having been exposed to this virus? And the figure works out to almost over 500,000 people in Nairobi could possibly have been exposed to the virus and are already carrying antibody. This information is extremely important for us because it gives us an idea of how the virus has permeated the community and what the level of transmission is. Of course, as you know, the test that we do, the RT-PCR test, could not be able to give us this kind of data. Because of the way in which we are targeting this test, most of it is targeted in the sense that we identify positives, we follow them, we do the contact tracing and so on, and at some points we also do a little bit of target testing in certain areas. So this information is extremely useful, and it is information that will feed into our modeling projections to be able to give us now more real data to work with and perhaps improve the predictions that our models are likely to make. I have to say that, one, the sample size is okay, fairly small. Two, it may not be perfectly representative of the country because these are samples from blood donors. We know blood donor samples, particularly at this time of the pandemic, are biased in a way because most of the samples that we are getting right now in the blood donor bank is people who are donating blood for their relatives who may require blood transfusion. And when that is not the case, even then our blood donation mostly comes from volunteers in the younger age groups, school children going, university students, and so on. So in that sense, the sample may not be accurately representative of our population and the distribution within our population, but we are continuing to build up on their samples. We also have other work streams that we are going to look at that will improve that representation so that we have data that is much more stronger in terms of its reliability. I will have Dr. Baraza respond to that, I think, after the DG has also responded to the questions that have been directed to us. Finally, the question from citizen was on COVID-19 test kits. How many have been approved in the country? I would want to restrict it to the gold standard test that we are doing right now, which is the real-time PCR test or the nucleic acid-based test. I believe we have about 5 or 6, yes, approximately 5 or 6 that we have approved. And we know where these tests are being conducted. We are also aware that there are reports out there of discrepancies in results coming from different labs. Yesterday I talked at length about that. There could be a number of reasons why tests there would be discrepancy in the results between different labs. From all the way from the supply chain, the point where the sample is collected and how it ends up in the lab and how it is processed, to differences in machines and the sensitivity of the machines or the setting of the machines. And the way to address these things is that we have both an internal quality assurance program as well as an external quality assurance program. Particularly the external quality assurance program is one that compares results from labs of samples that we already know their state, and then we share it with labs and we see what they return to us. And then we can be able to detect where there are problems and work with those labs to try to clear up those problems. And there was a final question from the Standard newspaper. Okay, your question was those who came in with underlying conditions, whether they knew that they had these conditions, and then what was the level of, did the treatment that they were getting for these underlying conditions affect their course of COVID-19 infection. I think this information is available. I'm pretty sure that the DG can also respond to that. So allow me now to ask the DG to respond to the questions directly.
Go first.
Or Baraza, come over here. You are going to talk about the asymptomatic study, yes. And then we can seroprevalence study.
Thank you very much, Bonakas, and good afternoon, everyone. So I'm going to respond to two things. One is around the question on asymptomatics and the concern about whether a high level of asymptomatic patients is a good or a bad thing. So when we say that patients are asymptomatic, what it essentially means is that they have the infection, but they are not presenting with symptoms. And we know from the case data that the ministry reports on that we have a high level of asymptomatic patients. And that is not a bad thing. It is a good thing in the sense that it means essentially that, number one, the people are not sick, so they're not suffering. And number two, it means that they do not present a burden to the health system. Because remember, one of the things you're worried about with this pandemic is the potential for it to overwhelm our health system. So if most of the patients are asymptomatic, then it means that it preserves our ICUs, it preserves our hospitals, and so on. So it is not a bad thing. It is a good thing in a number of ways. And secondly, just to respond to the study that we did on the seroprevalence of COVID, I think a lot of the questions have been comprehensively handled by the CAS. So mine is just to reiterate that, number one, as mentioned, these findings are only preliminary. So we are continuing with the analysis, and you will get more data as and when we finalize on the analysis. And secondly, again, to reiterate that they are indicative, and this is because, as mentioned, blood donors are not 100% representative of the population. We know, for instance, that the people that donate blood are younger than the general population, and so on and so forth. So these are indicative. And a third thing to clarify is that when you do seroprevalence, when you check for antibodies in someone's body, you're not checking for whether that person is infected now. You're checking for whether that person has been exposed in the past. So the PCR test that we keep talking about tell us that this particular person has COVID-19. But the antibody tests tell us that this person was exposed to COVID-19 in the past couple of months. So there are three things that I wanted to clarify. And again, as mentioned, we are now using this data to inform our modeling work to be able to answer questions such as the question that Wahiga Mwaura has asked, which is, what does this mean for our epidemic curve? So this is something we are now working on with the new data that we have to be able to answer those questions. Thank you very much.
DG.
Thank you, Waziri. The first question was about the COVID cases in ICU in public-private hospitals. Yes, that data is available and we can be able to share with you. But as of today, the figure is evenly balanced. 14 people are in ICU in public health facilities and 15 people are in ICUs in private health facilities. And of these 29, 13 of them are on ventilatory support and the remaining 16 are getting supplemental oxygen. I think 15 are getting oxygen, then 1 or 2 are under observation in the critical care unit. But let me also just highlight that the management of COVID patients is an expensive activity. There's a study that was done recently that shows that on a daily basis you'll spend about 21,300 to manage an asymptomatic COVID case. So if suppose now we test one of you and take you to KU Teaching Referral Hospital today, by tomorrow your bill shall have accumulated to 21,300. If it's a mild case, it will cost about 21,400. And if it is a severe case, in which case you may require supplemental oxygen, the figure rises to 51,000 shillings per day. And if it is critical and you require ventilatory support, that figure goes to 71,000 shillings per day. If you look at these figures, they are not sustainable in the long run. They are going to overwhelm or impoverish our people going further. And the major contributor or major driver of this cost, of course, is the PPEs, which you have to don at each and every time you see a patient. The same study shows that home-based care is 9 times cheaper than institutional care. And it is with that in mind that we develop the home-based care guidelines to be able to remove the pressure from the health facilities and also to reduce the economic burden of keeping people in the hostels. Second question from Brian was the use of the sanitization booths. Yes, we have sent an advisory to the counties based on information that we received from WHO that the sanitation booths or cabinets or tunnels don't add any value. Remember, the primary mode of spread of COVID-19 is droplet spread. So even if I spray you with 10,000 liters of chlorine, that will not stop you from coughing the moment you leave the tunnel or the cabinet, and therefore spreading the disease. Based on that, it was decided that we stop using these sanitization booths. Further, when you use chemicals like chlorine, hydrogen peroxide, or quaternary ammonium compounds, which are used commonly in those, then they expose you to risk of bronchospasm. In case you are an asthmatic, you can get a severe attack of bronchospasm, which could lead to respiratory failure and even death. Then in terms of skin, they will also cause skin irritation, leading to what is called contact dermatitis and also eye irritation. So with that advisory in mind, we have sent word to the counties that they pull down all those sanitization cabinets or booths. Well, the recoveries, if you compare our recoveries with the global figures, they really match. There's not much disparity. However, different countries have implemented different interventions. Like countries which have gone ahead to fully implement the latest WHO guidelines that say that even from the 8th day, if the patient is not asymptomatic, you can send them home. If country X decides to implement that to the fullest, then of course their recoveries will be much higher. But for us, we still stick to 10 days plus 3 days of being symptom-free. So basically, we send you home on the 14th day. So it depends on what criteria the intervention a specific country is using. But if you look at our recovery rate vis-a-vis the global average, they compare very, very well indeed. And the recovery rate should also not worry you so much. I would wish you concentrated more on the case fatality rates if you compare the number of people who are dying, because that will be telling you about the quality of care that you provide to your people. As of today, our case fatality rate is 2.29% compared to the global average of 6.7%, so which is a third. So I want to applaud the healthcare workers for the excellent work they are doing to manage COVID-19 cases. The COVID-related death, the bills, yes, in the public health facilities, the bills are catered fully by the government. In the private sector, because one makes a choice to which facility he or she goes, then the only way the government can be able to support, and which we have done on a number of occasions, is in case particular families overwhelmed by a bill, is to negotiate on behalf of the family for a credit facility or sometimes even waiver of the bills so that the burials can be done. Underlying conditions for COVID-19, I don't know whether it was deaths or COVID-19 in general, but in terms of deaths, the main underlying conditions is that if you have a combination of high blood pressure or hypertension and diabetes mellitus, that is the greatest risk, followed by hypertension on its own, then diabetes, then cancer, HIV, and other chronic health conditions. But we are doing a study on patient characteristics to be able to tell us what kind of patients develop what kind of conditions, including those who require ICU support in terms of ventilatory support or supplemental oxygen, vis-a-vis those who remain asymptomatic even when they have existing conditions. Brian asked about whether we can be able to tell the compliance of the patients before. Yes, there are some tests that we can be able to do. Like for diabetes mellitus, there's a test that you can be able to do. You check what we call hemoglobin A1C. It will be able to give you a snapshot of how the control was 3 months before. For blood pressure, it will be very, very difficult, but it will be assumed that if the patient is compliant to the medications prescribed by the clinician, then the control will be good. But I think we'll be able to get more data from this study to be able to inform us. And going forward, of course, we are confident because we are using locally generated data to be able to design our interventions, as compared to before when we relied on data from Europe and China to be able to project how the disease will look like. I thank you.
Okay. Thank you very much, DG. Thank you, all of you. But we still have something to do, which is the launch of the documents. So I think you can now join us for launching of these documents.
Na ujambo mpenzi mtazamaji, imekuwa taarifa kila siku baada ya saa 24 ripoti inatolewa kuhusu msambao wa virusi vya korona, na ni dhahiri shairi kwa virusi hivi vinaendelea kusambaa kwa kasi zaidi. Leo mpenzi mtazamaji, visa 247 zaidi vya korona vimeweza kuripotiwa nchini, visa vyote vya korona vikifikia visa 7118. Watu 39 zaidi wapona virusi hivyo na kufikisha idadi ya waliopona nchini watu 2148. Watu kati ya visa hivyo 153 ya visa hivyo vimetokea katika kaunti ya Nairobi, vile vile 35 kutokea kaunti ya Mombasa. Mpenzi mtazamaji, watu wawili zaidi waaga dunia kufuatia korona, idadi ikifikia watu 154 ambao wameweza kufariki. Vile vile mpenzi mtazamaji, visa vyote vya korona vimeweza kupita 7,000 sasa, na vile vile jambo lingine hapa, kati ya visa 247 hivi sasa ambavyo vimeweza kuripotiwa, 163 ni wanaume na vile vile 83 ni wanawake. ni idadi tu ya visa ambavyo vimeweza kuripotiwa siku ya leo. Ikumbukwe ya kwamba visa hivi, mpenzi mtazamaji, leo visa 247 vimeweza kuripotiwa, huku watu wawili wakiaga dunia. Kaunti ya Nairobi imeweza kuripoti visa 153 kati ya visa hivyo 247. Hivyo basi, mpenzi mtazamaji, taarifa hizi na zingine unazifuatilia kwenye Facebook TV47 Kenya, ingia kwenye Twitter @TV47KE, na itakuwa furaha kuweza kusoma jumbe zako zenye ambao utakuwa umetuma hapa, na tutazidi kusonga mbele, mpenzi mtazamaji. Na tukiendelea kusonga mbele na taarifa zaidi, hivi sasa tunaarifiwa ya kwamba tutakuwa tunavuka kuelekea katika majengo ya Seneti, bunge la Seneti kunradhi, ili tuweze kupata kikao ambacho kinaendelea hivi sasa, tuweze kujua ni yepi ambayo yanajiri. Tukisonga mbele ni kwamba kaunti hizi ambazo tukizidi kusonga mbele ni kwamba zitakazonufaika kutoka kwa msaada wa euro milioni 2.5 kutoka kwa Umoja wa Ulaya kupitia shirika la Amref kusaidia kuimarisha juhudi za kaunti hizo katika kukabiliana na janga la corona. Kufikia sasa, kaunti ya Uasin Gishu imerekodi visa 90 na vya watu walioambukizwa virusi vya corona. Hebu tutazame.
We mentioned the 90 cases in Uasin Gishu. Those are estimates. We believe the figure could be high because of low testing. And therefore, we need a lot of support because the testing kits and reagents are very expensive. We cannot afford much as a county. Aware that the Great North Road is going through our county, and therefore, the likelihood of contacts with the people who are suspected to be infected could be higher than those who are not close to that highway.
Around $5 million euros that is dedicated to community engagement and COVID response. It supports around 20 counties in Kenya. Amref is working with 9 counties, and Uasin Gishu is one of them. There is Nairobi, there is Kajiado, there is Machakos, there is Kitui, and Nakuru. And basically this support is to complement you. We are not coming to duplicate. There are many partners working in Uasin Gishu. Ours is to come and facilitate where there are gaps. And at the moment we are looking at really how do we support the isolation centers? How do we support the healthcare workers who are working in isolation centers? How we provide basic supplies like PPEs, things like sanitation equipment and materials.
And the numbers continue to rise each day, and we have put in several measures from the beginning. We started with sensitization. At least now everybody knows what COVID is and the methods of spread. What we need now from the community is just implementing what we already have sensitized them on.
Na bila shaka, mpenzi mtazamaji, nilivyokuwa nimekuahidi kwamba tutakuwa tunavuka na kuelekea katika bunge la Seneti. Hivi sasa gavana wa kaunti ya Kitui Charity Ngilu anahojiwa na kamati inayohusika na masuala ya uhasibu wa fedha za umma. Na moja kwa moja sasa tunafululiza ili tuweze kusikiliza ni yepi ambayo yanajiri, kwa sababu naarifiwa kwamba anazidi kukabiliwa na maswali magumu kuhusiana na namna anatumia fedha za umma. Twende moja kwa moja.
Page and which document? Is that document 2 or what? Yeah?
It's page 47, Mr. Chair.
Page what?
Mr. Chair, may I ask that maybe the auditor will also go to 6, 7,
no,
we can answer them all together.
In the same page so we know where you are.
Chairman, I think this is on page 47. And Chair, also on a point of order, I agree with the governor that since there are projects quite a number, we could kindly go through them up to maybe 6.1, so that we can.
Yes.
I think I've already ruled. Let's not go back with my ruling. I've already ruled.
All right, thank you.
But I don't have page 47 here. Second document.
Thank you, Mr. Chair. I will ask my officers to take us through that section. Straightforward.
Go ahead.
Page 47 says the management responds that the procurement department has already provided the project procurement file to the audit team, which has all the necessary documentation.
Can you remove your mask?
Sorry. Yeah, it's on.
Sorry, Mr. Chairperson. These are the reason why I'm saying some of them are very straightforward is because some of them are almost completed. Because we need them, especially during this COVID. So at the time they were not, but right now.
See, we'll reach there.
Sorry?
Let us make that decision. For you, you present your answer now.
Okay.
Yeah.
So 6.5. The stored construction of outpatient block at Kitui Referral Hospital. The project is 95% complete, and the contractor is currently on site doing the minor finishes to enable the project to be operational within these 3 months, next 3 months, if not earlier. The construction of outpatient block at Mutomo Sub-County, the construction of outpatient department patient block at Mutomo Hospital. The project was awarded in 2016-2017 financial year at a cost of 7.4 million shillings. Currently, the project is done up to substructure level. Due to delays on the part of the contractor, the project contract has been terminated. The ministry is in the process of retendering the remaining work so that the project can be completed within this financial year.
Auditor General?
No.
Sorry, I seem to be having a different response from the management.
Actually, we have the response, but I'm trying to give you in a press form.
No,
I
no,
don't have to read the whole
No,
thing,
no,
but I
no,
can
no.
read the whole
Governor.
thing. I'll give you what you have.
Write what you have written down.
The procurement department has already provided the project procurement file to the audit team, which has all the necessary documentation. And the ministry has put in place measures to complete the project so that it can be fully operational. That's why I say in the next 3 months, 95% is completed. And on 6.6, the procurement department is sourcing for the relevant documents which will be availed to your team in due course. And the ministry has put in place measures to complete the project so that it can be fully operational. The county government, through the Department of Lands, Infrastructure and Urban Development, has initiated the termination process. The county treasury has sent the money through FMIS, KRA, and we have printout on this.
Auditor General?
The issue raised here was, I think we can classify them into two. One is availability of the procurement records, and if I go to 6.5, the response is the procurement department has already provided the project procurement file to the audit team, which is not part of this response, so we've not been able to verify that. The second one about completion, the governor has just confirmed that it has not been completed, despite the project having been started in the year 17-18 or before. The second paragraph on the construction of outpatient block at Mutomo Kitui South Sub-County Hospital, I believe. The procurement department is sourcing for the relevant documents. Again, we were not in a position to verify them. The ministry has put in place measures to complete. That again is an admission that the project is still not complete. And then the other one is the county government through the Department of Lands.
Na bila shaka mpenzi mtazamaji, ni gavana wa kaunti ya Kitui Charity Ngilo akiwa mbele ya kamati ya seneti kuhusu masuala ya uhasibu, akijibu maswali kuhusu matumizi ya pesa ambazo ni za umma. Ikumbuko ya kwamba mpenzi mtazamaji, hivi sasa anaulizwa kwamba kuna pesa ambazo hazijaweza kuwekwa kwenye mfumo wa IFMIS ambazo ni shilingi bilioni 1.5, na vile vile namna ya kutoa kandarasi za kaunti kuna sheria ambazo hazikuweza kufuatwa. Taarifa hiyo utakuwa unaipata katika mwendo wa saa 1, vile vile saa 3 kwa kina zaidi, kwa sababu inafuatiliwa. Mpenzi mtazamaji, kwingineko ni kuwa Benki ya Dunia imetoa ufadhili wa awamu 2 kwa kaunti ili kuimarisha sekta ya afya. Waziri wa ugatuzi pamoja na mwenyekiti wa baraza la magavana Wycliffe Oparanya amedokeza kuwa awamu ya kwanza bilioni 1.6 kila kaunti itapata milioni 30.
Dear, we are happy to release to the counties level 1 of this facility, which is Kenya shillings 1.4 billion. And this is money that has already been disbursed to the counties, and the governors have already confirmed that the money has been received. These 1.4 billion is shared equally by all the 47 counties, and each county will be receiving 30 million for capacity building. The second level, level 2 of this KDSP program is Kenya shillings 4.6 billion. But this is not going to all the 47 counties. It is being released to 38 counties that have qualified. And we want to thank the World Bank and the team that prepared this after vetting all the counties, and to congratulate those 38 counties that will be benefiting from this facility. We will be circulating to you a list of the 38 counties that gives a breakdown of what each county will be receiving from the 4.6 billion facility. And we are very, very grateful that most of this money is actually going towards improvement of our health facilities and improvement of health services.
Na bila shaka mpenzi mtazamaji, ndo taarifa ambazo tunazidi kukupakulia. Tukizidi kusonga mbele ni kuwa wakulima wa maziwa katika kaunti ya Kajiado wanalalamikia malipo duni ya mazao yao. Wafugaji hao wanasema kuwa wanapokea shilingi 30 kwa lita moja ya maziwa, kipato ambacho hakiwezi kukimu mahitaji yao ya kila siku. Wakulima hao sasa wanaiomba serikali kuongeza bei ya maziwa hayo ili waweze kujimudu kimaisha.
Naomba kitu moja kwa Shaledi ya Barnard. Nasema nisaidia mama Rabasali. Saa hii kiangazi ndio mingi. Na mama iko na maziwa mingi. Mungu amenyesha na amepata nyasi mingi. Na mama iko na maziwa. Na nyinyi anateremsha bei. Naomba leo ipandisheni maziwa ya mama. Mama atapata 30 na atakamua lita 10, mama anapata lita 5. Ndio gharama ya barabara. Na naomba tu kitu moja. Corona ameingia. Na naomba nyinyi ujali nini masilahi ya watu yenu.
Kwa wakati huu wamama wale wanauza maziwa hapa Masaini na vijana wale wanaokota na pikipiki wasipojisaidia wakati huu, sioni ni wakati gani tena watasaidika, kwa maana kiangazi ndio hiyo naye inaendelea kukaribia. Na maziwa kawaida huwa tunapatanga kwa muda wa mwezi 3 hivi 4. Ikifika mwezi wa 7, mwezi wa 8, hii ni kiangazi inaanza kutangaza huku, kulingana na maji yanapopatikana mbali na ng'ombe sitakuwa zina hama, haitapatikana tena maziwa. Kwa hivyo tunaona Buruku site, tunaomba tena kwa heshima kubwa wajaribu namna ya kupandishia hawa watu transport at least wapata hata kitu kidogo, maana hiyo bei iko chini sana, inaumiza wakulima ingawaje mwalimu anang'ang'ana sana namna ya kusaidia hawa, lakini kusema kweli wanaumia.
Matiang'i amehapa kuendeleza mchakato wa kubana michezo na kampuni za ubashiri nchini. Matamshi ya Waziri Matiang'i yanawadia baada ya bunge la kitaifa kuweka sheria ya kupunguza ushuru unaotozwa kampuni za kamari na michezo mingine ya ubashiri, huku akiahidi wizara yake itapendekeza marekebisho katika sheria hiyo.
And we are going to remain strict. Where challenges have been in the past, and I think it's fair to be very sincere with the public, challenges have been at the licensing point, where we have licensed people in the past who ought not to have been licensed in the first place. And since a year ago, we have walked away from that. No one has got to worry. So many people have called me, religious leaders, faith-based organization leaders. I just want to assure everyone, we are not going back on that policy. We want sanity to prevail in the country. That thing was very badly managed in the past. It almost destroyed our families and our children. We will not go back to it. And then under no circumstances we are going to allow that kind of madness to continue. We cannot allow, criminals, money launderers, from some places in Eastern Europe to come and do in our country what they can't do in their country.
Na mpenzi mtazamaji, katika kaunti ya Narok, afisa upelelezi katika kaunti ya Narok Mwenda Ethaiba amehakikisha kuwa wanawatafuta waliochochea vita vya ukoo katika eneo la Narok Kusini na Narok Kaskazini, vita vilivyosababisha vifo vya watu 10. Kamishna wa tume ya uwiano na maridhiano NCIC Abdulaziz Farah amewataka wanasiasa kukoma kuchochea watu wao kwa misingi ya
kufika siku ambapo tutakupata umevunja sheria, tutakuchukulia hatua tukisaidiana na NCIC, na sio lazima NCIC wakuwe hapa ndio tufanye kazi. Sisi tuko tayari na tuko hapa kufundishana mambo ya sheria kuhusu mambo ya uchochezi na zile makosa zingine ambazo watu wanafanya wakati wanaongea. Niambia watu uchochezi haitasaidia chochote, kwa sababu uchochezi imepelekea watu kukufa, watu wamepoteza maisha. Mpaka sasa kule Narok South na Narok North karibu watu 10 wamekufa, na tunawatafuta wale ambao wameleta hiyo uchochezi ambayo ishia kuleta vita na watu wamekufa. Wale ambao wamefanya hayo tunaendelea na uchunguzi, na kuna watu wengi ambao tunachunguza, wengine wameandika statement, na baada ya kuandika hizo taarifa bado tunaendelea kutafuta hasa kiini cha hii vita imetokea wapi. Na niwaambie kwamba wakati wa kuvunja sheria umekwisha. Hapa Narok tunataka watu wakae na amani.
Kenyans, we must live as brothers and sisters. And for those who are bent on creating disharmony in this country, the law will not forgive you. The long arm of the government will catch up with you. NCIC will catch up with you. The National Police Service will catch up with you. And therefore, every Kenyan, individually, collectively, it is our responsibility to make sure that this great country is in harmony with this.
Mtazamaji, kwingineko ni kuwa kwa kile kinachoonekana kutokuwa na maneno ya kupendeza kwa gavana wa Iguru, naibu gavana wa kaunti ya Kirinyaga Peter Ndamberi ametaka uchunguzi kuanzishwa ili kuweka wazi matumizi ya fedha za kaunti hiyo. Haya yanajiri huku gavana wa Iguru akikwepa msumeno wa kubanduliwa wiki iliyopita baada ya kamati maalum ya seneti kusema kuwa madai dhidi yake hayakuwa na uzito wa kumbandua. Hata hivyo, wawakilishi wadi wa Kirinyaga wamesema kuwa kuponyoka kwa Waiguru sio mwisho wa mchakato wa kumbandua.
We should also be accountable to you. Na mtu akiulizwa swali kuhusu utumiaji wa pesa, either iwe ni baya ama ni nzuri, mtu anafaa kujibu. Na kama ni sisi gavana tunaulizwa maswali na MCAs, tunafaa nasi tujibu. And I would want to say that we all belong to Kirinyaga and we shall live as Kirinyaga people. Si ni kweli? I would want to hate kusikia kuna ma MCA ambao hawezi fanyiwa kazi because of their political affiliations. Ama kuna sehemu tuseme kama hii hamutatengenezewa barabara kwa sababu MCA wenu amesema hivi ama ile. We deserve service equally in the entire county and in the entire country.
Na sasa mpenzi mtazamaji, tukielekea Kilifi, ni kuwa kundi la kina mama 200 la wauzaji samaki limefaidika na msaada wa boti 3 zitakazowasaidia katika shughuli zao za kila siku. Kulingana na kina mama hao, boti hizo zitawasaidia kuvua samaki na kuziuza, hii ikiwa ni njia moja ya kukimu mahitaji yao.
Utapata samaki ni wengi, lakini utapata baadhi ya kina mama hawahifadhiki katika wale samaki. Nikaamua kama mama kuunda hii group ambao ni Pweza Women Group. Nikaitisha wenzangu, nikawashauri na nikawaelezea kwani sisi hatuwezi. Akasema sisi tunaweza. Tukaamua kuja kuunda sasa group ambayo inajiita Pweza Women Group. Tumefanya registration tukiwa watu 33, na kila tukizidi kukua kina mama sema mimi pia nataka chama, na mwambie ingia. Kufikia sasa hii tuko group ya watu 55 kina mama. Tumefurahi sana kwa sababu ya kansela wetu. Hatujasikia hapo kansela ambaye ametoa chombo kwa kina mama katika bahari yetu ya Kilifi Central. Hata hii ndo mara yetu.